That was terrific. Thank you. What we're going to have is a reactor panel now and then open it up for conversation. So I think we're very pleased to be joined by Julian Harris, who's the president of Care Allies, Melanie Bella, who's currently an independent consultant and was the first director of the Medicare and Medicaid Coordination Office at CMS, and Carolyn Ingram, who is the vice president of public policy at Molina. So I'd welcome them to come up. We're going to hear their reactions to these presentations and then open it up for discussion.
Good afternoon or morning, I'm not sure. I think we have 5 to 6 minutes. I could spend hours telling you what I would do differently now that I'm outside of CMS and seeing some of these things happening on the ground. I'm going to make a couple of comments first on the BPC report and then talk a little bit about some of the barriers I think that government has created to the spread and scale of some of these models, unintentionally, but still created. So on the report, of course, it won't surprise those of you who know me that I'm thrilled to see a report putting forward recommendations that push the conversation. I actually would love to see it push for a new title or various other things that might make this even easier, but we didn't quite get there. A couple of points I would mention. I think it's important to give permanency to the DSNPs, to the Medicare Medicaid plans, and to making sure that PACE is in a good place. We're not getting continuity of care and the investments we need with constant question about the ongoing sustainability of the programs. That said, there are really important modifications that need to go along with that permanency, and I'll touch on a couple of those. The second thing is, unfortunately, states are not in a position, many of them, to move toward fully integrated programs yet. So while we're waiting for many states to get access to those programs for people that live in those states, there are things we can be doing in really important areas that will make the two programs work better together. There are things around grievances and appeals. There are things around coverage standards, especially for home health and DME. Two areas where it is the worst, where those programs interact in the worst ways in terms of helping people and helping these kind of models. We can be doing things about those now. And another big area is around enrollment and marketing. There are things we can be doing in every state that are mostly administrative that would help us alleviate some of these barriers. The last thing I would say is, as we think about making those models permanent, when we set those models up, they were for risk-bearing entities, and the risk-bearing entities are typically health plans. There are lots of providers who come to us and say, we want to take risk. You know, why can't we be at this table? And so as we think about all the movement toward value-based payment and getting away from fee-for-service, we do also need to think about ways to bring the long-term care world into that in ways that isn't happening today. And the providers are not in a position that the plans are to take full risk right now for Medicare, Medicaid, and Part D. But we need to be thinking about good ways to be helping those relationships solidify a little bit better, I think, between the plans that are getting the money and the providers who are delivering the care. So in the remainder of my time, I'm going to say a couple things, and this is, you will love this. Like 3 weeks ago, I was out visiting with a woman who's in charge of this care management system for a group of providers in Southern California, and they participate in the California demo. She knew I had been at CMS, but the first thing she said was, you know, I spend 50% of my time checking boxes that some bureaucrat developed. And I thought, well, that's right. That wasn't intentional, and there are reasons why certain things were developed at certain times, but there are also reasons why those things need to be revisited over time. And so I'm going to mention, like I said, a couple of those. One is, and this is really specific to the duals demonstrations. I think we're getting a lot of learnings from those. So the first is around 3 parts of what I'll call the care model. And those 3 parts are the health risk assessment, the care plan, and the interdisciplinary team. So there are states that have these demos where they have requirements on the HRA that it has to be done in person, in the home, by a nurse. We don't need to have that sort of one-size-fits-all prescriptive approach for all people. It goes back to the ability to segment and the ability to use resources wisely. And those requirements got there for a whole bunch of reasons, including fear that the health plans were just going to take the money and run and people weren't going to get what they need. But as time has passed and we have experience on the ground, we need to feed that back into policymakers. So you heard me mention engagement the other day or earlier today. I'm pretty sure that in Massachusetts, where the demonstration is just for people under 65, a large number of them who have mental illness and substance use, I'm pretty sure our requirement to get in their house within 90 days has significantly caused disenrollment and lack of engagement. And it was, again, done for the right reason. But if we think about segmenting, we need to think about segmenting across all parts of these kinds of models. So the second common theme is just on the care plan and the interdisciplinary team. When you talk to people in the field, the requirements that made a lot of sense are really hard for them. And it's really hard, especially I think some of the interdisciplinary team requirements that we're asking the providers to do. And I'm guessing that that causes a lot of the reaction by the providers, which try to get people to opt out of these models. And so we just need to think about all of those things. The second piece I would say from a policy perspective where I think we kind of shoot ourselves in the foot with this population is around a whole host of enrollment issues. I call them enrollment, they could be eligibility. We are not consistent at all in how we treat this population. In Medicaid, you can waive freedom of choice. In Medicare, you have to protect freedom of choice. But in Medicare, we also allow for an ongoing special election period. So you have people that are changing plans all the time. You have brokers that are going after them in some products and brokers that aren't allowed in other products. So our most complex population, arguably with the greatest functional limitations to understand these programs, are the ones that are like feeding frenzy for brokers throughout the year. They're the ones that are getting steered in and out of plans. We have got to step back and look at that. There's got to be some consistency across the programs because it's negatively impacting our ability to engage members, and it is especially negatively impacting their continuity of care. And so I think that those are the ones. I'm sure I'm probably out of time, although I really could go on forever. So I will pass to Julian. Thank you.